Hi, I'm Dr. Paul with Chiropractic Secrets of Success, and we've opened 77 offices in 20 states. And today I'm going to just go over what equipment should you get. And this is really coming out of school starting. What is the equipment that you should consider getting? And definitely what equipment should you not consider getting? And let me just share with you up front, you can actually start with no equipment at all and just adjust patients. There's absolutely nothing wrong with that. Typically, why a lot of doctors won't do that is they don't have a lot of confidence in themselves. That is real typical coming out of school. I remember when I came out of school, you always thought you needed a therapy. Well, after you practice a while, it doesn't take very long before you treat several patients before you go, wow, this chiropractic thing really works. I really don't need, these other therapies. And then it also depends on what your philosophy is, what system or what model you're going to have. And a lot of times when I ask doctors, what system or model is your patient education based on, or your practice based on, they kind of look at me a little confused and go, what are you talking about? Well, there's different models. So the equipment you need is going to be based on the model that you're going to want to practice. And some models are unbelievably expensive, to be honest with you. Let's just run through a few. So when you go through, let's say you're doing a symptom practice, well, you don't need any equipment at all. It's symptom based, and that's kind of like the joint. It's just symptom based. They come and get treated, and they leave. So you don't need any equipment at all. And by the way, the less you know and the less knowledge and skill you have in any other model, that's what you'll get, because the market, people don't want to come in. And when they do come in, they don't want to come in 3 times a week, twice a week or whatever, and pay $50, $70. That's not what people wake up wanting to do. So that's called market forces. So you'll naturally get market forces. The less knowledgeable and the less skill you have, and it doesn't matter what model, that's what you'll get. You'll get more symptom care until your knowledge or skill goes up. Okay. So having said that's the symptom model. There's you could look at another model is like the chiropractic biophysics model. Well, that's very intense therapy. Those are expensive machines. They take a lot of labor. Now, remember, when we talk about equipment, what do we want to do, especially when you're starting a practice? We want good equipment. We don't want expensive equipment. And we definitely do not want any leases. These are some of the, there's a handful of things that make your overhead go up quite a bit. And having leases on equipment is one of them. So these are all major considerations. So these are some guidelines to go by. So having said that, and just by the way, just so you do know, when I'll share with you the model that I used, our total cost to equip an office, and I'm not just referring to the clinical side, I'm also talking to the administrative side, was only $7,000. And all of that was new equipment. And if you looked at just the clinical side, you were looking at $3,000, no more than $4,000. And for 3 therapy stations, adjusting table, in other words, enough to see over 100 visits a week. And I'll go in more in detail with that. So I just want to say up front, the equipment cost can be and should be real low. And we'll get into some of the reasons it's not, like a lot of times these students will buy these expenses of a piece of equipment because they used them in school. And of course, that's why the equipment companies put whether it's their table, their therapy or whatever, that's why they put it in school. They want the kid to get used to it and think that he actually needs it. Next thing you know, the student thinks he needs a $20,000 machine, which is not true at all. So chiropractic biophysics is one. It's science-based. It's really good with the science of the chiropractic adjustment, and it does a lot with structure. They do a lot with trying to correct neutral structure. And there's a lot of traction going on, long-term specific type of traction to affect the posture in addition to the adjusting. So those are expensive. Now, they make total sense. The science backs it, all that stuff, but you're dealing with expensive equipment. It takes up a lot of space. Those machines are big. and it takes a lot of labor. So these are major factors when we make decisions. We go, okay, well, how much does it cost? Um, how much labor does it take? How much space does it take? And what kind of return on investment? How much can you charge for it, or how much will be reimbursed by the insurance companies? Those are the considerations. So it's not just one consideration. I just want to do this. No, there's several considerations. And I see a lot of times doctors will get, unfortunately, they'll buy that expensive piece of equipment, 30, even I've seen even up to $70,000 for one piece of equipment. And 6 months later, it's sitting there collecting dust, and the doctor's got a jacket on it or something like that. It's not even being used. I can't tell you how many times I go in the office and that's the scenario. And I'll explain why that happens later. So chiropractic biophysics is one. So it's costly. You start, man, I've got a client friend who does chiropractic biophysics. He's got a huge office. He's got at least probably 3,000 square feet. And square feet is the death of overhead. That's the number one thing you don't want, is a lot of space. That just leads to everything else being higher with expenses, because you go to fill that space with space, labor, equipment, heating, cooling, electric. So I go in there and it's huge space, and then I see all these machines. I'm going, expensive, expensive, expensive. So I look at space and I go, expensive. Wow, I want nothing to do with this. Then I see all the big machines that take up a lot of space. I go, oh, I want nothing to do with it. And then I see he's got four they're kind of part-time people just helping put people on and off there, because it takes a lot of labor to position people on these machines, specifically with different foam and etc. I'm like, oh my God. I looked at that and it was a nightmare. I go, that's unbelievable overhead. So these are major considerations. We go into the subluxation model. A lot of times with the subluxation model, if anything, the subluxation model really focuses on the adjustment. They don't focus a lot on the machines per se. So you typically won't see a lot of machines, or you might see just some basic machines like a roller table or muscle stem or something like that. Every now and then somebody will wade out into the water and maybe buy a cold laser or, one of the latest gizmos. But the more straight subluxation the doctor is, the less machines they'll have. And remember, we're paying them multiple factors. Number one is your belief system. It's got to fit your belief system. Number two is overhead cost. Number three is labor, space, return on investment. So we're paying attention to all of these. So you just can't be wandering around and, trying to pick whatever you want. So, and I hear it reflected in the new graduates' voice, because I'll frequently ask them, I'll say, well, how much do you think it takes to open an office? And routinely they'll say $100,000 to $200,000. That's what they actually think, because their mind has been already jacked up. And I'm like, no, it only takes $7,000 to get all new equipment, to have at least 3 stations, to see over 100 visits a week, and have all your computer, your bookcases, your chairs, your posters. It's only $7,000. So if you actually know what you're doing, we can open an office for under $20,000. So I'm like, no, it doesn't cost 100 or 200,000, but you have to know what you're doing. You can't go crazy with equipment. You can't go crazy with space. We don't do any build out. So we go into spaces that are already built out, because build out is very expensive. And you don't get that money back. Build out's expensive. So it's like, that's a bad road to go down. And then sometimes it's a terrible layout. I just was in an office yesterday. It was individual rooms. That's actually the worst, least efficient layout that you can have. It's the worst space utilization you could do. So, but getting back to the equipment. So we talked about subluxation. We talked about chiropractic biophysics. There's a functional capacity type practice. And that really has to do with applying a lot more rehabilitation And that can be expensive depending on the rehabilitation that they choose. Because remember, it's not just the cost of the therapy, it's also the labor involved and the time involved. So you actually are losing money when you have to spend an inordinate amount of time with one person. So if that happens, you got to make sure that the reimbursement is there to compensate for that inordinate amount of the time that you can't see two or three other people. So these are all huge considerations. So some doctors are big into rehab, and it can be relatively expensive with therabands and what we would call like somewhat automated therapeutic devices like wobble chairs and things like that. But it gets really expensive when they start buying machines. And this used to be way bigger 20 years ago than it is now. Doctors would actually bring in, they'd buy. It was like you look into a doctor's office, it was like a mini gym. I mean, they had the big universal machines and the workout machines. And I mean, it was literally like walking in the half a Gold's gym. Well, that costs a lot of money. That equipment is very expensive. And again, it takes a lot of space. And then the labor can be modified. You can teach it. You don't have to be there one-on-one the whole time. So you can teach it to where they do it, then you oversight it. But those are serious expenses if you're going to talk about using that kind of therapeutic protocol versus rehab using like therabands, pinnacle cervical tractions, wobble chairs, wobble board. See, all of those are rehab functions, and you can literally have a station. You can set up a station for only $150, and it's real small. I can put up a TheraBand station, and it doesn't take any space at all. It's on the wall, so when nobody's sitting there, it doesn't take up any space. It just drops down against the wall. And when they do use it, they're only standing about no more than 3 feet out. That's it. So there's real high space utilization when you use things like that. Doesn't take much space at all, and it's very inexpensive, but it gets the job done. So that's another model. So we talked about subluxation, we talked about chiropractic biophysics, we talked about the rehab type of practice. Let me share with you the practice that I really fell for that totally made sense to me, and it's called the science of the 3 phases of healing. Well, we heal in 3 phases. There's the inflammation phase, remodel, and repair phase. That doesn't matter what model you do, that's how the human being heals. Doesn't matter if you practice subluxation or chiropractic biophysics. That's how people heal when they have injuries. And that's who typically comes to a chiropractic office. Remember, 84% of the people coming to a chiropractic office come for back pain, neck pain, headaches. 7% are for neuromusculoskeletal extremities. So 91% of the 8% that's utilizing chiropractic, it's neuromusculoskeletal, and it's injuries, pre-existing injuries, re-exacerbation injuries. That's why they come to chiropractors. So those are called the gateways. So the therapy that we use, what I did is I go, yeah, that 3 phases healing makes total sense. So we didn't push subluxations at all. We didn't talk about chiropractic at all. We talked about we did patient education that was based on what the patient could understand. Very difficult for a patient to understand subluxation, something they've never heard of in their life. And it's a very difficult concept to think you can give an adjustment and it'll affect your immune system, cancer, pain, headaches, everything in the world. That's a that's called one heck of a paradigm shift is what that's called. So there is such thing as a somatovisceral reflex, but in my experience practicing clinician, is that the number one reason people are coming in the door? No. And I've had the BJ Palmer or the Palmer experience. I had the patient come in who 10 years earlier was in an accident and they lost her sense of smell. And she came in and the very first adjustment, she walked out and she had her smell returned. That was the classic DJ Palmer, a pinched nerve right there, kind of, and I've had patients get treated. I treated with asthma, they got better. But I've also treated a lot of people with asthma that didn't get better, with a lot of conditions that didn't get better. They came in with back pain and they had a lot of other conditions, and those other conditions did not get better. Okay, so let's get back to not going into a cult and really going into the science. And that's what I am. I'm real big about the science and probability, not possibility. So when I looked at the three phases of healing, I thought, man, that's neat. That's fantastic. It's all about the patient. It's easy to explain to the patient. It's easy for the patient to say, no, yes. It has the natural motivators in her. I don't have to do any selling. I don't have to do any threatening, any selling, nothing, because it naturally has the motivators. It's got pleasure motivated. It's got pain motivation in it. I don't have to do anything. I just explain the way it is. And then all I have to do is make it affordable and respect their time. And I got a patient that's going to sign up for care. And that's what happens. So what are the what are the typical therapies that you can use that cover the three phases of healing that are relatively inexpensive, but yet you've got all the tools you need for the science of the three phases of healing? So here we go. Well, what is the therapeutic goal of the inflammation phase? Okay, that's the first. So you had to go, well, what's the therapeutic goal in each phase? Well, you need therapies for those therapeutic goals. So the therapeutic goal for pain and inflammation is to decrease pain and decrease inflammation and decrease associated muscle spasms. That's the therapeutic goal essentially on day one. And we're being very standard generic. Okay, so obviously there could be very unique situations, but I'm talking about just standard, what walks through that door 97% of the time. Okay, so what are the therapies? Well, chiropractic. Chiropractic definitely helps with pain with the gate theory. It definitely helps with inflammation with mobility, even if it's passive motion or the adjustment by imbibition. And that also helps decrease pain by removing the abnormal pH tissue, intercellular fluid out of the area, because that's a source of pain. So we're not only affecting the gate theory source of pain, we're affecting the chemical source of pain. Okay. So remember, there's about 6 sources of pain. Okay, so we got the chiropractic adjustment with passive therapy or the active adjustment with gate theory or with affecting the pH within that tissue by imbibition. Now, what's another therapy? Well, I always use them, have ice pack at home. And by the way, you never have a therapy in your office that you don't get paid for. Never. So they do an ice pack at home. They can do an ice pack at home. It's no problem. And then what we did is we did have the cold spray, but we only use that on acute patients. And chiropractic offices don't get severely acute patients. We get subacute patients. We get re-exacerbated injuries that are subacute. That's by far the class of chiropractic patients we get. So I did have the spray and stitch, the cold, I believe it's called ethyl chloride. Hardly ever used it. That wasn't even routine. That was really for somebody that was bent over, or, their neck was contorted, or they were bent over and they couldn't walk up straight, that kind of thing. Okay, so, and then muscles, then we did the electric stim. Electric stim is pretty inexpensive. Back in the day, we could buy a new unit for $400. You can probably get the same unit now for $600. One of the real common ones is the Amrex machine. Okay, and how does that work? Well, it works on the gate theory. And then also, if you tetanize, if it's on tetanize, if you put it on pulse, then it now also works by imbibition, by pumping the fluid out. And again, one of the sources of pain is an abnormal increase or decrease in the pH level due to interstitial cellular damage. So if we're working on inflammation, we just put it on pulse. Okay. If we're working on the gait there, we put it on tetanize. Okay. So that essentially was our therapies. Day one was chiropractic, not day one, but the inflammatory phase. So it's typically chiropractic, and then rarely spray and stretch. Very rare. We didn't even do that once a month, probably. And then, like I said, the chiropractic adjustment could have been passive. It could have been an osseous. And then also we can work to decrease muscle spasms or reciprocal inhibition. If you're not familiar with that, neurological facilitation, reciprocal inhibition, that works extremely well to deactivate muscle spasms. That works very well. That's not equipment again, that's the doctor. And then you have the e-stim, and we didn't buy these $3,000 e-stim machines. And these are all new too. We didn't when we opened offices, we didn't buy used equipment. We bought new equipment that matched and looked good. But what we didn't do is buy the $3,000 machine. And one thing you can't do either is you can never buy one piece of equipment. As soon as you do that, somebody's waiting. And remember, when people wait, that's the number one cap to growing a practice. You won't be able to grow a practice when people come in and wait. Matter of fact, the rule is they'll give you 12 minutes before they get frustrated. And remember, that's the single greatest complaint visiting a doctor's office, waiting, and they get frustrated after 12 minutes. So you can't have people wait and expect to grow your practice, which means you can't have one therapy. Now, if you're seeing 20 visits a week, you could probably get away with it. But you take your practice up to 60, 80 visits a week, you're going to have people waiting. Well, there's a saying called Mother Nature abhors the vacuum. In other words, you always have to have a vacuum in your office for more to come in. What does that mean? It means if it's a stopcock, people aren't moving, Mother Nature is not going to pile more into it. So you always, doesn't matter how busy you are, I'm seeing 300, 400 visits a week, patients could sign in and come right back because of the layout, design, the systems, the training, everything. There was no waiting, okay? So you have to always have a void. And that's why I say you always need a minimum of 3 tables. And that's just, not 3 tables, 3 therapy units, whatever it is you buy, to get it at least over 100 visits a week. Usually you can see about 120, 130 visits a week with 3 units of therapy. That's usually what you can do. And then to get past that, you'll need another one. And then to get up to, maximum capacity around 200, you'll need a minimum typically of 5. And again, it depends what therapy you're doing, how much time. Is it a passive therapy or is it a rehab active therapy? That makes a big difference. And is it an attended therapy or an unattended therapy? Well, attended means it's going to take more labor and time. An active therapy means it's going to take more time. A passive therapy, they're just put on and off, but it's not time regulated. Okay. So these make a difference. So in this case, the stim's not time regulated. The chiropractic time's not regulated. You can just the patient 30 seconds and be done and get paid, the full amount, just as if you stayed in there for 20 minutes talking to them, you're going to get paid the same amount. So that was the classic inflammation phase, the chiropractic adjustment or passive motion for reciprocal inhibition for the muscle spasms, stim for either tetanizing for pain or and spasms, or pulsating for circulation. And they use an ice pack at home. Well, what did that cost? Well, if you bought 3 stim units back, 3 times 6 is 18. Now they have a stim unit out. I can't think of the name offhand, but it's dual. So you can literally put it between 2 units. And this one side has its own controls and pads for over here, and this side has its own control pads for over here. So you can use all pads for one person, like neck and back, or you can use them for 2. and it's relatively inexpensive. And I can't think of the name of it right now. If I did, I'd say it. Now there's machines like that that are real expensive, but the one I'm talking about, I think, is only like $1,200. So it's like you can service two patients at the same time. So, which is fantastic. Or you can buy a $600 MREX machine. Well, three MREX machines is if it's 600 is $1,800. And now what we do is we use TENS units. So we won't even buy this. We'll start a practice. We won't even buy a $600. We'll use a TENS unit for the electrotherapy. And that costs like $50. Okay. So you can, again, what are we talking about? Space, labor, equipment. How much time does it take? And reimbursement. All of these matter. So in this situation, how much time are we dealing? Well, it's passive therapy. We put them basically on 5 minutes. That's it. We don't leave them on there 20, 30 minutes. There is no time structure with a passive therapy. There's times that are regulated with active therapies. And of course, active therapies get paid more. Passive therapies get paid less and less and less. So that's a consideration too. Some of these passive therapies only pay like $7 or $9. So these are all considerations on whether or not, you want to use them or not in your business model. Do you want to do a therapy that you get paid $7 for? And then you go, well, how much does the therapy cost? How much labor does it take? Well, how much space does it take? Well, next thing you can know, you could be going, well, forget that. I'm not going to spend that kind of space, labor, and equipment for a $7 reimbursement. See, and that happens a lot. And all of these are real factors. It's not just 100% get the patient well. That's not even real. And it's not even written into the reimbursement statistics. The reimbursement statistics take into consideration your thought process, how much time it takes, not just, get the person better, because it's real how much something costs for therapy or treatment or overhead. All those are real factors. And the only reason I say that is because when the students come out of school, they don't think like that. They're just thinking get the patient better. They're not thinking of overhead, labor, cost, time. They're not thinking anything like that. Well, that's not the real world. So real quickly, you find out about the real world. Because there's expense. You can't spend an hour with a patient at 4 o'clock, 5 o'clock in the afternoon, unless you're going to charge like $300, $400. You can't do that because you're not going to be able to see many patients, and you're not going to be able to pay your overhead. You won't even be able to see patients. You'll be out of business. So these are the realities. There's a lot of things to weigh in these decision making. It's not just, oh, I want that therapy because I used it at school. Okay, so that's a real good, solid inflammatory phase, very inexpensive. So, if you kind of look at the cost for everything we talked about, the total, if we're using the TENS units, it's $150 for the inflammatory phase. All our therapies were $150. Maybe throw in another 100 for the ethyl chloride. But remember, I don't even use that. That's for the severely acute patient. Okay, let's go to the repair phase. So remember what happens in the repair phase. The collagen tissue is now starting the scar tissue, collagen tissues randomly getting put in. Okay, so what's the goal now? It's type 3, so it's not as strong, not as elastic. So our goal is still to overcome, minimize, and eliminate any remaining findings of the inflammatory phase. And usually they do still have some residual pain, muscle spasms, to some degree. They're just doing better. Okay. So I'm still going to continue going after inflammation if it's there, tenderness if it's there, pain if it's there, muscle spasms if it's there. I'm still going to be treating those. Now I go into the repair phase again, and that's when the collagen is laid down randomly. Well, the goal there is to increase all 3 ranges of motion. So remember, every joint, whether it's the neck, the elbow, the shoulder, has 3 ranges of motion. not one. So remember, active range of motion, it's like if we look at my elbow as an example. Active range of motion is what the patient can do on their own. See, that's active range of motion. I'm controlling that. I can do it on my own. Okay. Then there's overpressure range of motion. Now the patient can't control that. It's from an external force. Okay, so here's an example. That's as far as I can go with active range of motion. But I'm going to go further. I'm going to apply an external force and I'm going to take it further. So here it goes. See, I can't do that on my own. That's overpressure range of motion. Now, once you go past overpressure range of motion, the next range of motion, and it's much smaller. See, so active is much bigger range. Overpressure is not as big of a range. Joint motion or paraphysiological joint space is even a much smaller range. So you got 3 separate and distinct ranges of motion. Now we're trying to get all of them back to normal, not just active range of motion. Because if you get active range of motion back to normal and overpressure heals permanently wrong, or the paraphysiological joint space heals permanently wrong, then that person will have a permanent problem the rest of their life. That dynamic, when it heals permanently wrong, is called pathological spinal biomechanics. That leads to the #1 disability in the United States, osteoarthritis. That's the direct path, osteoarthritis. Altered pathological spinal motor unit mobility. So we do pay a lot of attention to active range of motion. We pay a lot of attention to overpressure because now we're dealing a lot with motor units. And we're definitely dealing with motor unit range of motion when we talk about the paraphysiological joint space motion. And that's where the chiropractic is. When you hear the chiropractic adjustment, when you hear the adjustment, you hear the pop. When we do that, the doctor's gone through active range of motion. He's gone through overpressure range of motion, and he's taken it into the paraphysiological joint space of motion. It creates a cavitation in the joint. Remember, these joints have capsules. They're surrounded by capsules with lubricant liquid inside. And when it creates cavitation, it creates a negative pressure differential. When it creates a negative pressure differential, that's when nitrogen, which is very soluble, that's when the nitrogen in the fluid, the capsular fluid, goes from a liquid state to a gas state, and that's what causes the pop. Okay, so that's the mechanism of the pop of the chiropractic. Okay, so we want all 3. And by the way, that's why the chiropractic profession is the only profession that can help patients in all 3 ranges of motion. There's no other doctor or therapist that treats in all 3 ranges of motion. The closest to it is a physical therapist, and they typically are only in the active range of motion, not the paraphysiological joint space and not the overpressure. So the chiropractor is the only professional that actually can affect the repair phase of healing in all 3 ranges of motion. Okay. And you go, well, how big of a deal is this? Well, I just explained the #1 cause of disability in the United States, altered joint motion due to abnormal healing, which causes degenerative changes in the cartilage, the bone, Wolff's Law, Hodge's Law, muscle spasms, tension, the whole cascading effect. And then that's why people have trouble with when they have osteoarthritis. That's why they have pain, discomfort, restrictions with the most important things in their life called activities of daily living. That's why this is a big deal. And so a lot of people are healing wrong, not getting chiropractic care. They're healing wrong permanently. And that's why NSAIDs over the counter are the largest medications taken. That's what it's for. It's for the pain, musculoskeletal joint pain, movement. It's because they're suffering from that component has not been addressed. The medical route doesn't address that. And so you see all these people that heal wrong over and over and over. And now they're stuck with with permanent pathologically altered spinal motion. Well, now it starts to cause pain restrictions, degenerative changes. And so what does a typical patient do? They start taking NSAID medication. That's why NSAIDs is the number one drug seller that there is. Now, getting back to the repair phase of healing. So that's the goal in the repair phase of healing. So what therapies are we going to do? What are the best therapies? Now, remember, in the examination, we found all this. We can find restrictions in active range of motion. We can quantify it. Not just a range of motion, we can quantify associated pain with it. Same with overpressure range of motion. We'll quantify it. We'll look at the planes of motion, flexion, extension, right? And we'll evaluate overpressure range of motion and quantify. And we'll do the same with joint motion. Joint motion is quantified and evaluated through motion x-rays. Okay, so that's what we're dealing with. So that's the goal. The goal in the repair phase, collagen's coming in. In other words, it's like wet cement. Wet cement's pouring in. Are you going to allow that wet cement just to dry irregularly and create permanent problems? Well, that's the goal of the therapies, especially right now, physical medicine. It's to align all the collagen, put it in line, because that'll help increase the strength of the tissue. When it just goes in randomly, that's what creates weak tissue, re-exacerbations, and permanent problems the rest of their life. This is why 50% of back failures are failures. It's from the scar tissue that comes in after the surgery that heals randomly. The nerves get trapped in that collagen matrix. And when the patient moves, that matrix collapses and compresses those peripheral nerves. That's the number one cause. 50% of all back surgeries are failed. And that's the number one cause of failed back surgeries. Okay, so let's get back to the therapies that we need. So, okay, we know what's happening physiologically. We know what's happening physiologically in the inflammation phase. We've quantified it. Does the patient have symptoms, tenderness, inflammation? Is that right? So we've got all the quantification. So we know what therapies we need to employ. And then same thing with the remodel phase. We know that collagen's being laid down. We have to have some physical medicine to affect Hodge's law, to align that collagen up the best as it can, to increase the strength of that tissue, to decrease the likelihood of it becoming a permanent problem to some degree the rest of that person's life. And we need to do it in all three ranges of motion: active range of motion, overpressure range of motion, joint motion. That's what the chiropractor is doing. Now, what else helps? What else did we do to help do that? So in the remodel phase, we continued with chiropractic. Now remember, if they were still having any type of pain, we continued with the pain relief therapy. In this case, I said the stem or the TENS. And then also reciprocal inhibition or passive motion therapy for the imbibition. Okay. And then we not only have the chiropractic adjustment, but then we will add on in the repair phase, we'll add on reciprocal inhibition. And if you're not familiar with that, that does quite a few things. Basically, it's using the nervous system against itself to decrease muscle spasms and decrease the firing of the nerves. And when you decrease muscle spasms, you can actually increase range of motion with less pain. So reciprocal inhibition, PNF, peripheral neurological facilitation, there's different words that it goes by, is unbelievably effective in multiple ways. So you can use it to increase range of motion. You can use it to minimize pain. And we did, and you'll see results fast. I mean, as soon as you start doing, like if it's the neck or whatever, as soon as you start doing reciprocal inhibition, and the patient will see a difference real fast just from that one treatment. You know, they'll go from this to that, you know, this. They'll notice an immediate difference in how much further they can move without pain. So it's very effective. The combination of chiropractic with PNF is very effective for increasing ranges of motion and decreases pain. Now, because how many things are we working on here? Well, we got imbibition working to get the tissue, the fluid out. That's a source of pain. We're aligning the collagen so it doesn't trap the peripheral nerves during the healing process. We're using the gate theory with reciprocal inhibition and chiropractic. So there's several vehicles that's going on here, from inflammation to the nerve to decreasing the firing of the muscles, which allows for increased mobility. So there's several things going on here. Okay, that's the repair phase. So what kind of cost are we dealing with? Well, there's no cost associated with that. So where's our cost up to this point? 3 TENS units, $150. Let's go to the third phase. In other words, how much space is this taking? How much labor is this taking? Okay. Now, by the way, when we talk about labor, somebody does have to do PNF. And that, by the way, it's also not a passive therapy, it's an active therapy, meaning there are qualifications. There's time qualifications, whether you do it for 8 minutes or 15 minutes. And well, we always did a modifier. So the whole encompassing, and remember, the 8 minutes is not 8 minutes of full therapy, on the off. 8 minutes is the whole encounter, from you coming to the patient, how you doing today, scale of 1 to 10, any complicating factors, doing the therapy, stopping the therapy, and then documenting everything in your notes, your soap notes. That's the whole 8-minute encounter. Okay. Same with 15. 15, it's not 15 minutes of the patient doing therapy. It's 15 minutes for the whole counter, from how you doing today, documenting the subjective, documenting the E&Ms of the objective. These are qualifications for the soap notes. Well, they fit into that time frame. Then there's the adjustment, however long, or the treatment, however long that takes. Then there's the documentation. Well, now you got to go to the notes and you got to put in subjective, objective analysis, and the plan. Okay, so that 15 minutes is encompassing all of that. Okay, all right, that's how that works. So sometimes we'll just use a modifier. A lot of times in the stage 2 with PNF, we'll just use a modifier typically. So they could typically now be getting the chiropractic adjustment, the stem, and then they could be getting now a modifier with PNF. See where we're at? Okay. Then you go to the remodel phase. Now remember what happens in the remodel phase. Well, the collagen has stopped synthesizing. The type 3 collagen has stopped synthesizing. So what does that mean? It means there's a window. There's a very limited window to work with that collagen to decrease the randomness of the matrix and to align that type 3 collagen. And that's, of course, what the chiropractic adjustment does. When you adjust the patient, it not only affects them neurologically with the gate theory and the imbibition of the cellular fluid, it also affects the alignment. Because remember, wherever you put stress, your body responds. Remember, just like Wolff's law on bone, well, the same thing happens with Hodge's law on tissue. So when you apply that line of drive and that stress, that's when that tissue keeps lining up. Well, the more that tissue lines up, the less nerves that are going to get trapped in that matrix when there's movement. And it increases the strength. That's why. Okay, so now what are we going to do in the remodel phase? Well, we know physiologically what's happening. So remember, any of the biomarkers you're dealing with up to this time, you're still going to be dealing with if there is any other pain or whatever, okay? But now we're going to start adding on strengthening. So what's the purpose of strengthening? Well, that's the purpose of strengthening, is to align the collagen fibers so they heal aligned, which increases the likelihood of the person healing normal. It's when those collagen matrix go in randomly, and then the person moves, the peripheral nerves go everywhere. That's called hyperinnervation, reinnervation. It's another physiological fact that happens with your stem cells when you're healing. So it's your stem cells that are doing all this, producing all this area, the arterioles, the veins, the nerves. So now the stem cells are producing type 3 collagen, or the nerves. It's called hyperinnervation reinnervation. So there's some randomness to those nerves. Those nerves is what goes into that matrix. And when the person moves, it collapses on the matrix. That's why they can have no pain while they're standing or moving a little bit. But when they bend over to extremes, well, what happens to that matrix the further you bend? It collapses tighter and tighter onto those peripheral nerves that are trapped in the matrix. And that's why the patient can have no pain standing up, but now it's painful. And sometimes it even stops them from going all the way to the end of range of motion. That's why. So that's the goal now, is to increase the elasticity. And also remember, one of the physiological effects of that type 3 collagen is it's not as elastic like type 1. You're born with type 1. Well, the regenerative collagen is called type 3. So if it's not aligned properly, it'll be weaker. If it traps the nerves, it'll cause pain. And the natural properties alone do not have the same elasticity as type 1. So what does that mean? It means if it heals wrong with limited elasticity, it's only like up to 70% is strong or 70% is elastic. That's the genetic factors with type 3 collagen versus type 1. So what does that mean to the patient if it heals wrong? It means they'll have stiffness. That's what that means. They'll have lack of mobility. Now, it won't be in the beginning stages. It typically starts at the end stages. They can't go as far. They can't bend over as much. They can't move as much at the end. Now they start developing stiffness, and it's permanent. Well, that's part of the therapeutic protocol, is to try to decrease that from happening, try to decrease the type 3 collagen elastin, which has less elastin and elasticity, to get back to as normal elasticity as type 1 as possible. That's what the therapeutic goal. So by the time we end this therapy at MMI, hopefully we have the patient all the way back with the active range of motion, passive range of motion, joint motion, and normal elasticity with no neurological deficits, whether it's from hyperinnervation, reinnervation, cellular fluid causing pain, direct damage to the nerve causing pain, the nerve fibers getting trapped and pulled in the collagen type 2. These are all tight sources of pain that we're trying to eliminate. So it's not just pain, it's mobility, it's motion, it's connective tissue, it's scar tissue. It's all of these things we're trying to get back through physical medicine to normal, or what we call subclinical. So they could still have it to some degree, because we will always have, anytime we injure ourselves, it never goes back to 100%. So the whole goal is to get it to what's called subclinical, meaning, yeah, they could still have a little bit of trapping, a little bit of lost elasticity, but it doesn't affect the dynamics of the patient. Patient still has normal active range of motion, overpressure joint motion, and no pain. So it's there, but it's at such a low level, it has no effect on the patient's activities of daily living whatsoever. That's the goal of the therapy, is to get all of these physiological components that are bad when people heal, to get them subclinical, so the person does not have a permanent problem the rest of their life. So you can see that's the model I gravitated to, because it makes total sense, makes absolute sense. So that's the patient model we use for education. And because that's the patient model, what's the therapies I'll typically add in for the third phase of healing? I'll typically do TheraBands. Well, how much does TheraBands cost? Now, I don't buy that big machine that you can go into the books and go, where they have TheraBands for the pinkies, TheraBands for the index finger, TheraBands for the big toe. No, well, I want nothing to do with those kind of TheraBands. We just do TheraBands for the back and neck, the spine. That's it. That's it. We really dumb it down and make it simple, because that's all we're treating. Just remember the stats. 84% of the reason why people come to chiropractors is back and neck pain. Only 9% has an extremity So it's very rare that we'll be doing something for the extremity because that's not typically what we'll see in a chiropractor's office. Usually when a chiropractor sees an extremity, it's because the patient came in for neck pain or back pain. And oh, by the way, my shoulder hurts also, or my knee hurts also. That's the typical chiropractic patient. The typical patient out in the world doesn't have knee pain and think, oh, I better go to the chiropractor. They don't know. Most people in the real world don't even know chiropractors treat knees or feet or shoulders. They don't even know that. There's no branding with that. Okay, so that's the 3 phases of healing. So now I have TheraBands. It costs $150 a station. So you can buy these stations independently. You don't have to buy, the $3,000 model. So you can easily buy a station. All you need is an anchor board. Some doctors will just take a 2x4 and screw it into the studs of the wall, or they'll screw it in horizontally to make sure it's in the studs. And then they'll put like one up high and one low. So that's real sturdy. And then in those boards, they'll attach the TheraBand board. So it's real sturdy in the wall. And they could put multiple stations. So if you did that by 2 or 3 2x4s, however wide 4, 6, 8 feet, whatever that is, you easily can have 3 stations. Doesn't take up much space at all because it all just lays down. So it costs $150 a station. You go, okay, space, great with space. Labor, it's great with labor. I just teach the patient how to use it. And when they come in, they're required to use it on their own and we monitor them. So we don't have to have a therapist with everybody there all the time. We can have one therapist overseeing all of them. You can have one doctor overseeing everybody. So space, labor, equipment, time. What's their time? Now it is a rehab. It is active therapy. Okay. So it also pays more than passive therapy. So that's the good news about the active therapy. So space, great. Labor, great. The equipment fits right into what we're doing. Science of the 3 phases of healing, repair phase. And the cost, $150 a station. I got 3 stations for $450. Throw in, and we don't even start with tables anymore. Tables are worthless. You don't even need tables anymore. You need a table to do your exams and your adjustments, and that's it. But you don't need any therapy tables anymore. And then because that takes up a lot of space, and that can be equipment. And then even if in the past when we did do therapies, they were the inexpensive tables. They were the heritage tables, wood. They weren't the sleek, modern metal $3,000 table. Well, 3 of those is $3,000 to $9,000. I buy a heritage table back then for $400. I think they're about $1,000 now. So I'm into my whole rehab phase for $450. And then if you wanted to add on some pinnacle traction devices, those are about 150 each. Once again, where does it stand in space, labor, equipment, knowledge, and into the science of the 3 phases of healing? Fits right there. It's no big problem to put up a couple stations for the cervical pinnacle traction. I can put a lot more stations on with TheraBands than I can with individual tables and therapies between tables. I'm way more efficient, doesn't cost as much, less labor, and it's way more specific to what I'm doing, the science of the 3 phases of healing. It's way more clinically applicable to helping the patient. And you get paid for those. You get paid better for those. And if you wanted to add a third one that affect the core muscles, that would be like a core stabilizer. You can buy core stabilizer chairs. If you go through Pinnacle or something like that, they're pretty expensive. They're not like $350, but you can go online and you can find them for $30 to $50. So again, you can buy 3 of those core stabilizing therapies for what you're at $130, $90, $150. So so you can see I've got all 3 phases of healing covered. I got the inflammation phase, the repair phase, the remodel phase. I'm dealing with all the components of the neurology, trapped, hyperinnervation, reinnervation, trapped nerves, direct damage to nerves, intracellular fluid causing pain. I'm dealing with all of those with our therapies. And then I'm dealing with, so that's the pain, chiropractic, osseous, passive motion, reciprocal inhibition that helps with using the gait theory, helps decrease pain, decrease muscle firing, decrease muscle spasms. Okay. Note there's no cost. That's just you. A little bit of time in you. Or I taught my therapist to do PNF, and we always did a modifier. And you got your stim, help with either tetanized muscle spasms or circulation or gait theory pain, $50 each, 3 stations, $150. So where are we at? We're at $150 for the inflammatory phase. There's no additional cost in the repair phase. And it's $450 in the rehab phase. I've got all three phases of therapy covered, all 3 phases of healing covered. And what did it cost me? $150, $450. I'm under $1,000 for my therapies, just like that. Fits exactly into the clinical model. Patients understand it. Care is based on the patient's biomarkers relative to the science of the 3 phases of healing. Everything's quantified. We'll know exactly how the patient's doing at every re-exam. We'll know exactly what phase of healing they're in. And when we're done, we'll know if they've healed with no problem at all, or maybe they're going to heal with some type of pain or restrictions at MMI. So maybe we lessen the degree of permanency, and that's beneficial too. And it's all been quantified and justified. So that's the model that we use. It's easy to explain to the patient. I'd kind of dumb it down even more when I talk to the patient about how this works, but it makes complete sense to the patient. I'm not pushing chiropractic. This is how they're going to heal no matter where they go, but they're not, wherever they go, they're not going to get all 3 phases in one spot. You go to the physical therapist, they're only going to get the rehab phase, and it's only going to be active range of motion, not overpressure or joint motion. You go to the general practitioner, they'll get pain medication, anti-inflammatories, which is fine for the inflammatory phase. Doesn't do anything for the rehab phase. Doesn't do anything for active, passive, or joint motion. There's no other provider that can do what I just said. We cover all therapeutic protocols with any injury, major, minor injury, re-exacerbation through all 3 phases of healing and the physiology that's happening. What's the natural physiology that's happening? So we know how to document it, quantify it, use the therapy specifically for those biomarkers, and reevaluate it with re-exams, see if it's getting better, worse, staying the same, and then move to the mixed therapy phase, quantify. Again, from the beginning, we can quantify pain, tenderness, muscle spasms. We quantify all that. And that's important so we can see how the patient's doing, how are they responding to the therapy. Move them into the repair phase. We quantify active range of motion, overpressure range of motion, joint motion. It's all quantified. And we'll apply the appropriate therapies, again, for the physiology that we're finding with the biomarkers relative to the science of the 3 phases of healing. And it's very easy to quantify strength and elasticity and the therapeutic outcome from strength and elasticity until we reach MMI. We reach MMI, that's the end of the line. That's it. So that you either got the patient, you either got all of those negative findings below threshold. If you've done that, they're fine. They have no permanency. If you didn't, they're going to have a permanent problem to some degree. That's how it works. So that's what's so great about the science of the 3 phases of healing relative to the business model. Patients now understand what happens in each phase and what we're doing and why we're doing it. And that symptoms aren't the only one. There's like 8 major biomarkers. Well, we teach the patient to pay attention to all 8 of it, not just symptoms. We want them to know about all 8 of the tests, not just one. They understand that. And then, so there's your cost. So that's the business model that we use. And that's why I use it. And I couldn't justify any other business model like I just did with that. If we went into chiropractic biophysics, subluxation, symptom care, any of those others, they don't give space. Look how much little space I need. Labor, look how little the labor I need. Equipment, I don't have to lease anything. And by the way, we do not start an office with an x-ray machine. It's too easy just to send them down to the local MRI center until the office is profitable. And then we do not want to sign a lease. You never want to sign a lease. Leases, space and leases is what get doctors into overhead, high overhead. So that's why we always have high space utilization, multiple space usage, open areas, not closed areas. That's what creates the most space utilization. We have the least labor that's needed. Matter of fact, the therapies that I just shared doesn't need a therapist. One doctor can do everything I just said in very little space. And then same with reimbursement, because you don't want to do a therapy you don't get paid for. You'll go broke. So we're covering all the clinical aspects. We're getting paid. We're doing it in highly efficient space, highly efficient labor, highly efficient cost, high profit. And it makes total sense to the patient. That's the model that we use. So what was the total cost? 10 units, say for three, let's because you need at least 3 units. You can never buy just 1 or 2 units. You buy 1 unit, you're stuck at 20 or 30 visits. Now you got somebody waiting. And waiting is a practice killer. You can never have people wait. So you always, when they come in, like especially after hours, you got 2 or 3 people that are on the same therapy. You better have 2 or 3 therapies available and ready. As soon as 3 people come in and you only have 2, you just gutted your practice. Even if that you're only seeing 80 visits a week, you just gutted your practice. It's not going to grow when you have people wait. So 3 will get you up to typically about 120, 130 visits. 4 will take you typically like to 150 to 160. And but I had 6 therapy units, so we could see 300, 400 visits a week with nobody waiting. And that's how. So what was the cost with 3 stations? 3 10 units here. So that's 150. No cost in the repair phase. And $150 a station for the TheraBand, $450. $450 plus $150, $45, $600. The whole therapy for all 3 phases of healing, $600. And high space utilization, low labor, low cost, and good reimbursement. And specifically, it covers exactly what you need for all 3 phases, the physiology of the science of the 3 phases of healing, which is how we heal with macro and minor traumas and re-exacerbations. And that's who comes into a chiropractor's office. Okay, so let me leave it like that. Those are some of the models that you want to consider. That's what the topic was today, is what therapy you should consider using and why to consider using it. I just gave you like the most efficient therapy to use with the best model that makes the most sense. That was it right there. So you're about $600 for your therapy. Buy your adjusting table. Your adjusting table, again, we don't buy the $3,000, $4,000. We damn well don't buy the $5,000, $6,000 Zenith Hilo. We'll buy the $600, $800 Heritage table. That's it. And then that's most of your cost. You know, you got your doctor's bag and all that. You do not need an x-ray machine to start. And then you got your chairs, posters, plants, computer, bookcases, file cabinet. That's what I say. It's under $7,000. It costs us less than $7,000 to equip an office with new equipment fully. We just explained that was anywhere, but that was about $3,000. You put the table in and all that therapy, that was about what, $2,000 to $3,000, depending. The most expensive cost is going to be the table. And that's if you go haywire and buy these, you know, these $3,000, $4,000, $5,000 tables. So if you don't, you get the new, you know, Heritage tables, real sturdy, wood legs, even if you wanted to get the manual drop, if you do some drop every now and then. But I'm not buying a $7,000 electric drop table. You won't even be able to move it yourself. You have to hire people to move it. So that's all you need. That's it. And there's all kinds of business out there, just even just back and neck pain. You don't even need to go anywhere else. It's all we ever treated. That's all we ever marketed. When we cover marketing in a totally separate section. So anyway, let me wrap up the equipment. There's your equipment. So that was what, under $3,000, 600, 6, 7. Yeah, definite, depending on how many units you had. It's definitely under $3,000. Let's say one bit, that's 450 rehab plus 150 for $600. That was $600. The whole therapy for all 3 phases of healing, $600 cash, done over. And it's totally directly exactly what you need for helping the patient with 3 phases of healing. And nobody's waiting up to about 120, 130 visits because we need 3 stations, not 1. There you go. Need another station, you start getting busy, somebody's waiting, add another $150 station. So even if you took it up from 3 to 6, that's 4, that's $800, $900. $950 roughly to have 6 stations of therapy. You'll be able to see more patients than you physically can handle with 6 therapy stations. There you go. Again, I'm Dr. Paul, Secrets of Chiropractic Success. Hope that helps you out. Give us a call. By the way, give us a call if you want any more information about this. We do consulting. We help doctors open their practice, start their practice, grow their practice. Obviously, we know how to do all this. We've opened 77 offices in 20 states. I've been consulting and training chiropractors how to start and grow the practice for 30 years now. So give me a call if I can help you.